Welcome to our webinar today on demand and capacity modelling for COVID-19 recovery. Today we'll be talking you through the updated core model. My name is Sandra Eismann. I work in the demand and capacity team, and with me today is Khunpha. We'll be talking you through the webinar today. I'll give you a bit of background about the webinar, and then Keith will give you a demonstration of the revised core model. As a bit of background, the core model was published in 2018 to support the modelling of elective care services. It is a generic model which can be customised. Some of you might be familiar with the previous IST models. Some of you might have used them, so these are the models developed by the elective care intensive support team. The core model is very similar. It uses similar principles with some added functionality. As a demand and capacity model, it measures two metrics when looking at demand and capacity. It looks at required capacity versus available capacity. On the bottom right-hand side, you see a small screenshot from the core model. You can see the required capacity that you would need for the service that you are modelling. That's the blue bar on top. So this is the capacity that you would need to meet the demand coming in for your service. The model will tell you your available capacity, your core capacity. So that's the capacity that you have available on a recurring basis. That is the cross in the middle of the screen. And the model will also tell you your capacity, taking into account any ad hoc capacity, so capacity that you have from time to time. And that's the line you see in the middle of the screen. As a second metric, the model will look at your current waiting list size versus the sustainable waiting list size. In the NHS, we are familiar with waiting lists and we are familiar with our services having waiting lists. The question is, when does a waiting list become so large that it will be impossible for you to catch up with the waiting list? So your waiting list will continue to grow. And your patients won't be seen on time, and the model will calculate that point for you. If you would like to learn a bit more about the principles underpinning demand and capacity, for example, percentiles. So percentiles is about where do you set your capacity, sustainable waiting list size, I've just mentioned that, or about statistical process control charts, which are used in the core model to look at your data and decide whether your data is good enough to predict. If you would like to know more and you have like 15 minutes, watch our fundamental videos. On the right-hand side, you'll see a video of Sandra, who will be talking you through SBC models. If you have 40 minutes, watch our introductory webinar. So that was the first webinar that we recorded as part of the summer series. If you have 60 minutes, visit our online training course, and we'll send the links will be provided in the slide deck, and on Future NHS next to this recording you'll find a PDF version of the slide deck, so you'll have access to these links. On the webinar today, Keith will be talking you through the changes made to the core model to support planning for elective care services post-COVID-19. If you haven't used or seen the core model before, today might be a lot to take in. If you would like to familiarise yourself more with the existing core model, you can watch a walkthrough on our website. We're displaying the link here, and it's a step-by-step guide on how to populate the whole model. If you would like to see how some of your colleagues have used the model and applied the model, visit our page on Future NHS. And there's a variety of services have been modelled, including acute, community and mental health services. For demand and capacity modelling, we advocate a PDSA cycle approach. So if I start at the top left corner of the diagram, the first step is to understand demand and capacity principles and tools. So that's the links that I've just shown you, the principles around percentiles, waiting list size, SPCs, and the tools, in this instance, the core model. The next step would be then to decide which of your service do you want to model? More specifically, what's the pathway of the service and which step in the pathway are you modeling? And then talk to your stakeholders. So that's your clinicians, operational staff, informatics colleagues, and anyone else, administrative staff, to kind of decide, okay, exactly what it is that we're modeling, and most importantly, what are we going to do with the outputs of the model. The next step then would be to populate the updated core model, and that's what we'll be focusing on today. Once you've done that, you kind of look at the model outputs and you go, okay, does this model actually match service reality? If this is the first time you are modeling this particular service, you might find that the answer is no. So in this case, it's something about looking at your data, looking at your assumptions that you've made when populating the model. So for example, when you entered your capacity, is that the actual capacity that is provided to patients accessing the service, or is it a capacity that's just recorded somewhere and that might be out of date? And it's very likely you'll go around a few cycles where you discover how your service works. Applying demand and capacity models in the demand and capacity modeling journey often can be a small part. So services often tell us modeling is actually the easier part. It's understanding your service. And what you'll find is, as you understand your service better, you will find improvements that you can make. So for example, a community service that recently modeled their service, they found they had a long waiting list. It was because their appointment system wasn't working well. So it was actually really difficult for patients to make an appointment or to reschedule an appointment. So you could say that's not really part of DNC modeling, but it was kind of part of this PDSA improvement cycle. At some point, you'll populate your core model and you look at it and you say, does it match service reality? And you go, yes, it does now. And then you can use the results to plan your service for the next few weeks. And if you do demand and capacity modeling on a more regular basis, which we advocate doing, this should also underpin job planning. Before I hand you over to Keith, let's just take a look at the current situation. So what has changed? So we're currently looking at elective care service reopening, which brings new challenges, and more specifically, we've updated the core model to reflect some of the new circumstances that facing services. Number one is potentially a decrease in registered demand due to the suspension of elective care. So some services actually have seen their waiting list size decrease, but that's because the referrals, for example, for GPs or other services, they're not coming in right now. So actually the question is, what is the unregistered, unmet demand that we're currently not capturing in the population? We expect an increase in our demand as services reopen, but we don't quite know how that increase looks like, and it's probably different for different services. So for a lot of diagnostic services, you will have seen that increase already, the increase in demand. Some services, especially if you're working with patients who are shielding, you might not see that increase because patients actually might choose not to go, for example, hospital, because they're shielding and they want to continue to do so. Some services you might see a reduction of available capacity. So this whole model around outpatients, where you have a lot of patients waiting in an area to be seen in various numbers of clinics, isn't possible right now due to social distancing. So the question is, how do you manage your patient flow and how does it affect your available capacity? For a community service, are there any additional safeguards that you put in place for your staff in the post-COVID-19 world, which take more time, and therefore you have less clinical capacity to tend and see your patients available? So the question is, how do all of these things affect the service that you're trying to model? And with this, I'm handing over to Keith.
Thank you very much, Sandra. So what I'll be talking about to begin with is just a quick discussion about the new sections that we've added into the core model, just to help accommodate these new planning needs that Sandra just discussed. So in the first instance, we're looking at demand. And of course, typically when we talk about forecasting demand, we need some historic data so that we can use that to make some educated guesses, which is basically what a prediction is, about what's going to happen next. With COVID and the change in how we're actually running our operating models, there's obviously a lot more information out there in terms of what trusts are putting together for their own predictive analysis. And so in order to accommodate some of this additional information, we're allowing both historic data as well as predictive forecasts that you might have developed yourself to be entered into the demand section. And that does change how some of that information will interact with the tool. In terms of the adjustments to demand in response to COVID itself, we've also included some basic scenario modeling. So this is talking about looking at, first of all, the understanding that, as mentioned, the registered demand, the patients that have been referred into a service, that might have decreased during the period where elective care is paused. But as we open services, there'll be an increase over time back to some baseline level of normal. And our first assumption in this instance will be that we're returning to some historic level of normal. So be it your historic demand or forecast demand, it'll go from basically your restricted level of demand back to your baseline quote normal. How long that takes, we can look at how that's actually entered, but basically that's going to be the first step in terms of modeling for the near future over the next few months, what's actually happening to your service. And we also will be looking at what we call the unseen or unmet demand, which are patients who would have ordinarily been registered as needing to be seen in your service via referral or some such, but haven't been able to because they haven't been able to go to their primary care provider via their GP or other kind of interactions with health services because they've been shielding or something like that. So once again, estimating that will help us anticipate further down the line what the pressures on our service might be. So those are aspects that we've adjusted to help look at what the incoming demand might be. The other section that we've looked at is also capacity, because obviously the new kind of changes that have occurred in how we're interacting with patients will also have an impact on capacity. So as Sandra mentioned, making sure that we have safe spacing for patients, and also potentially resource allocation, so reallocating resources and prioritizing particular services may mean that your service may not have the capacity it may have had before. And so in order to accommodate that increased pace of change in capacity, where we've made some adjustments to how you actually look at capacity, and we'll have a look at how that might be used to support your planning for your service in the coming weeks. So with that, let's have a look at the model itself. So if you'll bear with me just a moment, we will take a look at the tool. So what we're seeing here is the opening screen of the core model. And what I'll do is I'll just very quickly highlight where changes have occurred, and if any aspects of the main part of the tool aren't especially familiar, I'd highly recommend having a look at the video walkthroughs that were referenced by Sandra earlier to help you familiarize yourself with how the tool is normally operated. So in the setup screen, not much has changed. We can enter different modalities or subspecialties for specific processes. And all this allows us to do is wait appointments of different lengths to make sure that for a given service, say it's a diagnostic service, you might have CT scans that might take 20 and 40 minutes respectively. And so if you've got two streams of such patients, you can just weight them accordingly so that when you look at the totality of your scan time, you can make a fair comparison in terms of what you need. And similarly, if you're running a community service, you might have a more complex appointment length, say an hour and a half, versus a more straightforward appointment, which might be an hour. And so you can just basically make sure that you're allocating your capacity in an appropriate way. In terms of units, we can look at different types of units, patients, minutes, whoops. Let's go back to minutes. Minutes or points if you're using endoscopy services. We can set what the percentile calculations are, which basically allow you to look at your overhead, which will give you the appropriate safety margin to make sure that your service is keeping on top of its incoming demand. And finally, we can enter our current waiting list, which might have some impact because, once again, if we haven't been seeing patients, that might have been building up. So it's a good chance to check what's actually been going on in that regard from a perspective of reopening your service. So not a huge amount has changed in terms of the setup. If we look at the demand, we're entering our data on a week-on-week basis, and this is referrals into your service. So remember, demand is not the same as activity. It's actually what's actually been requested of your service. And we can split it by the different types of streams, as you can see here. So I mentioned that there's been a bit of a change. So this little box is a new thing, and you can basically change it. So we're looking at your own forecast. So any predictive analysis that you may have done or your partner organizations have supplied you with in terms of anticipating demand through to your service, well, you can enter that here and it'll look at that in its own right. And what this does is, rather than using SPC charts and things like that, it simply assumes that you've done all the calculations beforehand and takes it as written in terms of what you've actually put in here. So if we look at the demand adjustments for COVID, this is an entirely new section here, obviously. So what we can actually enter here is we can enable this function. And what this will do is that it will let us enter some new values. And these are some of the things that we were talking about just before. So the date, for example, from which we began experiencing the initial close down of elective care, for example. So we've put the end of March, which is approximately when lockdown started. And what we can also enter on top of that is the level of demand. So the number of requests that were coming in during that period where demand might have been restricted. So these would have typically been cases that absolutely need to be seen. So we were obviously prioritizing patients quite rightly to minimize the clinical risk, but we would still have potentially some small number of patients that were still being seen because they absolutely needed to. And this just helps us set that initial baseline for what we were actually expecting to come through. The second load of figures here just lets us have a look at the date at which we begin to reopen. So I've put the first week of June here. Once again, that's approximately when a lot of services started reopening their doors. And beneath that, we can enter the number of weeks we expect to phase from this restricted level of demand to basically going back to business as usual. And you can see that's what's happening here. This is accelerating up to our historic or our predictive forecast, depending on what we've entered. And the assumption here is that it'll happen in a fairly linear manner. So it's going straight up, and there's not that much else apart from that in terms of the calculations. So this gives us a first stab, at least, at anticipating what might be happening to our service down the line. And we can change this number to anywhere between 0 to 36 weeks. So if I put 36 weeks here, for example, you'll see it stretches out the time period quite significantly versus the 16 that was originally put in. So beneath this table, beneath this part of the sheet, we've also got a small section which just lets us look at that hidden patients cohort. So you might have seen that there are, based on these this dotted line, this is what we would have expected under normal circumstances. The gap between that and what we actually were seeing represents a cohort of patients who we might reasonably expect to have needed some form of clinical intervention and probably will in the not too distant future. So because they're not registered, they represent a hidden cohort that might be a surge that you see later on. And so what we've done here is just allowed you to actually quantify it in the first instance, so you can see that here, and then phase them over a set period of weeks. And that just gives you a sense of, if you were anticipating additional work coming in, what that might look like in terms of the shape of your demand chart. So you can see that green line on top of the red and blue lines here. So this green line here would represent the additional load on your service that might be caused by this kind of, quote, hidden demand. So hopefully you can see how with these tools, you can start to build a picture of what you might be able to anticipate coming down the line in terms of the demand that'll be running into your service in the coming weeks and months, and use the tool accordingly to provide some different scenarios. So you can adjust the numbers up and down here and say, what if it takes a little bit longer? Or what happens if it takes a little less time for my service to accelerate back to background levels? And what will be the implications in terms of how I manage my service? This will just give you some tools to help see that and to start putting some numbers around what you need to be planning for. So when we're looking at capacity, we can enter each of the sessions on a case-by-case basis. So this is exactly the same as the original tool. In terms of its application to COVID recovery, there's a couple of things that might be useful to consider. So we've always talked about the core capacity being your centrally regularly funded activity that you can actually support, with ad hoc being plus cost. So typically locum sessions or waiting list initiatives and such like. What we've heard from providers is that in a lot of cases, they may be outsourcing some of their activity, so going out to the independent sector. And what you may find useful, and what some providers have done, is actually split this between internally provided sessions, so sessions that were provided from within the trust, and sessions that are provided by the independent sector. So splitting it out that way gives a slightly different view. So depending on what's the priority within your organization, how you want to actually look at your capacity, this is an opportunity to actually look at how you're actually entering that and give yourself the view that you need to support your planning. Similarly, when you're actually looking at some of these clinics, you'll be wanting to link it back to things like your workforce planning, of course, and some of that will be built. You might want to consider how that builds in terms of how COVID might be affecting your ability to run sessions and such like. So let's look at the capacity summary, because this is where we've made some changes to how the tool works. So what we can see here, we've got each of these different sessions, and we can turn on and off these clinics on a week-on-week basis. So this is a standard functionality that's available in the main core model. So if you put an X in these little sections, you're turning on your clinics on a week-on-week basis. What we've added to this is just the ability to specify the actual size of the clinic on a week-on-week basis. So once again, what we've heard from providers and what we've seen done in terms of planning is that some clinics may be run on a partial basis in the run-up to opening fully, or there may be the need to provide overcapacity. So there may be the opportunity to take additional resources and provide clinics that are running above normal size. And in both those cases, you can basically change the size of your clinic. So we can say, instead of, for instance, in this instance, 150 approximately minutes per week, we're looking at 100 minutes, or we could change it to 160. And you can see it changes on a week-on-week basis. So this just lets you tailor your capacity a bit more sensitively to the demand profile that you're seeing, and judge as to whether or not that will be helpful for managing the risk to your patients in terms of keeping pace with the demand coming in, and of course ultimately to making sure that they're seen in a timely way. So that's the main the main change that we've made to the capacity summary section. So if I go through to the parameter section, not much has changed here. But once again, in terms of application to COVID recovery, what we've heard is that actually it's a really good opportunity to look at some of the patient attendance behaviors and how that might be affecting your ability to provide capacity to meet demand. So, for example, quite rightly, or quite understandably, patients may feel some apprehension about coming into a clinical environment. So you may find that there's actually a greater proportion of non-attendances. So rather than, say, a historic non-attendance rate of 3%, you might see that it's increased. And by measuring this, you might be able to see what impact that has. If you can't safely discharge those patients, the net result of that would be the need for additional slots to be provided. So that might give you some insight into what you might need to do in terms of patient engagement, in terms of things like making sure that patients feel safe or have the information they need to make a decision and inform you early, so that you can reuse slots as you see as you need to. So once again, this isn't necessarily about a change to the tool itself, but looking at how the changes in operational processes might be reflected in how you're actually representing the information here. So Sandra mentioned that we also look at the waiting list size. So this page is fairly standard. Nothing else has changed. This just lets us set the size of the waiting list by looking at the timeframes in which we need to be seeing people. And all this builds into our summary page. So here we can look at very much a very similar view to what we saw on the capacity summary page, a view of what you need to provide, which is the thick blue line, and what we are able to provide, which is the dark green line as the core capacity and the light green line as the ad hoc capacity on top of that. Or it could be the independent sector capacity that you have outsourced in, depending on how you're using this tool. And this should give you enough information to start making a judgment call about the risks to your waiting list increasing at different points in time, and whether or not that's something that you'll be able to tolerate in the short term, or may have to take some remedial measures in the form of extra sessions or such like. The second thing that you'll see here is your waiting list position, and what you'll be wanting to see is your sustainable waiting list size, how big it should be, the size that is consistent with delivering care within the time frame that you need versus what you actually have. So obviously, if your current waiting list size is above your sustainable waiting list size, there's a risk that your patients may be waiting longer than you want them to be. So the final section I'll very quickly cover is the planning section. This basically lets you play what if in a slightly more interactive way. So basically you can start to say, well, what if my non-attendance rates were actually 20% instead of 10%? Or let's bring it back down to 10%. Or even let's put it to 3%. It just, whoops. Let's not put big numbers in here, 0.3, there we go. 30%, but you can see that this affects obviously the required capacity, and it lets you once again start to play with the numbers a little bit more and see what the impact of different decisions might be and help you inform how you're actually going to be managing your service. So hopefully that overview has given you some insight into the capabilities of the tool, but also in terms of how you might use the tool in relation to your own challenges when it comes to looking at post-COVID recovery. So very quickly, in terms of how you can actually use the updated model at a local session, at a clinic, or very operational session, it's a good way of actually sense checking what's going on the ground, especially with regards to capacity, because that's the thing we've been hearing a lot about, that's changed. At a service pathway level, this just helps you identify the critical elements of your pathway, which might be bottlenecks to your service that you might need to focus on in order to ensure that you're getting patients moving through the whole pathway as effectively as possible. And at the more strategic scenario planning, if you're looking ahead a little bit further, this might give you the opportunity to look at what might happen if, say, for example, we needed to plan for a second wave of lockdowns because of second spikes in infection, for example, and also for part of our annual planning, because we can actually look at the activity coming in through the year and make some calls on that. So I'll just hand back over to Sandra now to talk us through the final bits.
Thank you very much, Keith. So we're almost at the end of the session. Thank you very much for joining us today. I hope you find it useful. If you would like to download the latest version of the core model and the guidance, please follow the link to our Future NHS website. If you don't have access to the space or you have trouble accessing the space, just send us an email. Otherwise, that just leaves me to say, please do stay in touch.
And wishing you all the best.
Thank you very much, Keith. Could we look at the last slide? Thank you very much. Please stay connected, visit us on our website, do sign up to our bulletin. All of our work and publications in terms of models are advertised via the bulletins, and join the Demand and Capacity Network on Future NHS, the one I've just mentioned, and do follow us on Twitter if you want to. Thank you very much to Edwin for helping us record the video, and thank you all very much for listening. Bye-bye.